Okay, and welcome everyone to the second HEAL Headliners webinar. My name is Parisa Parsifar, and I'm a Health Science Policy Analyst with the NIH HEAL Initiative. We're excited for the webinar and presentations today. Before we begin, I have some housekeeping items to share. To provide comments or questions, please open the Q&A, which is probably located toward the bottom of your screen. If you need technical assistance, please type the issue into the Q&A and a technical support representative will respond to you. Today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. And I have a few announcements before we get started. I'll just pop that up on the screen. Looks good. Okay, perfect. Next month, HEAL Connections is launching a webinar on Thursday, June 8th from 1 to 2 p.m. Eastern that will spotlight the Justice Community Innovation Network program and strategies for engaging communities in sharing impactful HEAL research. HEAL Connections is also forming a panel of people who have firsthand experience in living with pain or are in recovery from opioid use. If you or someone you know is interested in collaborating with researchers to identify better ways to use and share research findings, please learn more at the link posted in the Q&A box. And now it's my pleasure to welcome Dr. Rebecca Baker, Director of the NIH HEAL Initiative. Rebecca?
Hello and good afternoon, everyone. Thank you for joining us for this second HEAL Headliners webinar. Today's webinar topic, engaging patients and communities in HEAL research, is very important to me personally and is very important to our goal of helping to end addiction long term. As a research initiative aimed at helping people affected by pain and addiction, HEAL prioritizes incorporating the perspectives of patients, stakeholders, caregivers, families, and communities in our research. Scientific solutions for the opioid and pain crises will not be meaningful without considering how and how well they'll work in the real world and with real people affected by pain and addiction. And so today I'm very, very pleased to be co-moderating the session with my friend Don Edwards, a person living with chronic kidney disease and a member of the HEAL Community Partner Committee. Don is a self-described chronic kidney disease warrior. She has experienced firsthand every renal replacement modality I read here, including a kidney transplant and rejection. And as a home hemodialysis patient, she has a wealth of insight into the needs of people with chronic kidney disease, always keeping in mind that patients need different things at different times in their lives. She's dedicated to improving the quality of life of people with kidney disease and is a resource to her community by sharing her story and educating people about the relationship between hypertension, diabetes, and kidney disease, especially among underserved communities. I got to know Dawn through the HEAL Initiative, where she serves as an advisor to the HOPE study that we'll hear more about in today's webinar. She is an incredible individual and resource to us at the NIH, and so I'll now pass things over to Dawn.
Thank you so much, Rebecca. It's really my pleasure to be here with you all this afternoon. And as Rebecca said, I am a 33-year kidney patient. I'm from New York, New York, and I got involved in the HOPE study through an investigator, a doctor that I had done work with before. And it's been my pleasure to be involved with the HOPE study as a patient advisor. And as a patient advisor, I got to really experience what research was like. It was something that I had never done before. And it was interesting to me because I had always been taught when my growing up not to get involved in research or science because it really wasn't geared towards people of color. And the investigator that asked me to get involved, um, all he did was just ask. We had worked together before, and he came up to me and told me about a study that they were doing on opioid use in hemodialysis patients. And he asked me if I was interested in being involved as a patient advisor. And he told me what the study was about and why they were doing it, and that it was to help patients on hemodialysis. And once he said that, I immediately wanted to become involved because I've been a patient advocate for over 25 years. So anything to help my fellow dialysis patients, I was interested in being involved with. And what was really exciting about being involved in this study was that in the very beginning, we were invited not to sit in the back like patients usually do when they're involved in things. Dr. Kimmel invited us to sit in the front, and he told everyone in the consortium that we were patients and that he wanted us to be valued and he wanted us to speak up and be involved. And by him doing that, he empowered us to speak up. And if we didn't understand the acronyms or we didn't understand something that was going on, he wanted us to ask questions and to speak up. And that really made us feel welcome. And with the other people in the consortium, they spoke to us and they asked us about our experiences, and we were invited to share. And that made us all feel very welcome. And I'm going to introduce at this time Dr. Kirsten Johansson, and she was the leader of the committee that I served on, which was the recruitment committee. And Dr. Johansson was another one that made us feel so welcome. And she was just great with us. She valued our opinion, and we had great discussions in our committee. So Dr. Johansson is a nephrologist and director of the nephrology department at Hennepin Healthcare in Minneapolis, Minnesota. As part of the HOPE trial, she is testing various non-opioid treatment approaches in patients with chronic kidney disease to develop personalized treatments based on individual patient needs. Her patient-oriented research focuses on patients with chronic kidney disease and end-stage renal disease who receive dialysis that can cause muscle weakness and pain. So, Dr. Johansson, um,
I'm here.
here you go.
Thank you, Dawn. Thank you so much for that kind introduction. Boy, it's great to have that kind of lead in. I think Dawn could probably give my presentation better than I can, but I'll try to follow on that, and Dawn can correct me if I say anything wrong here. And exactly what I was afraid would happen, which is that it just froze, even though it didn't do that in the testing. Very strange. Let me just try this one more time. Apologies. Okay. So this is an outline. I'm gonna go through just very briefly what is patient engagement, and then we'll go talking about and giving some examples of how it worked in the HOPE study. So patient engagement is when patients meaningfully and actively engage in governance, priority setting, and conduct of research for the mutual benefit of the patients, the researchers, and the broader population. And there are many frameworks around this, but I kind of liked this one that talks about levels of engagement. So sometimes when we think about patient engagement, especially until recently, it's been more about having them participate as patients in the study, as participants rather, or sometimes as consultants to provide some feedback after we've already figured things out for the most part. But it can go all the way along to having an advisory board that continues through the study, or to collaborating at all levels of the trial. And then finally, even to patients leading their own trials. And the HOPE trial really fits in this collaborate part of the spectrum. I may just need to leave this on the regular slide view. Let me just go back to sharing again here. Let's just see if this works better. So why do we do it? Well, we do it because patients bring their perspective as experts from their own experience and knowledge gain, just as Dawn was talking about. They know what it's like, and we really don't. And by doing that, then they increase the patient-centeredness of the study design and the outcomes. They can help ensure that there's meaningful and culturally appropriate study materials. They can help improve recruitment and retention. And those are the direct benefits to the trial. But as a bit broader, if we sort of take a philosophical view, it really injects more democracy and accountability into the whole process, and it empowers patient stakeholders rather than researchers coming on from on high and deciding what needs to happen. So I want to shift and talk about the trial, but I'm really just going to skip to maybe the most fun thing about it here, which is showing you the video that our patients created to make this trial the best it could be. And I do not see the link. Excuse me 1 second. Okay, there it is. Everything works better in practice.
My name is Dawn Edwards. My name is Dave White.
My name is Carolyn Wilkie, and I have spent the last 10.5 years on hemodialysis.
I have been a kidney disease patient for 28 years. I spent a total of 6 years on dialysis. I have renal osteodystrophy, and I stepped off of the curb one day and I fractured my hip. And it was the worst pain that I ever experienced in my life. For me, pain and kidney disease go hand in hand, unfortunately. I remember when I was first diagnosed with kidney failure, the doctors were asking me, where does it hurt? And the only answer I could think of was it hurts all over.
One of the times that I've had pain was when I got my third access placed, and it was a really big surgery and they had to make a pretty long incision. And ever since that incision, I've had nerve pain in that arm. And it's something that I just kind of have had to live with because there's not a whole lot they can do about it. It was really difficult for me to explain my pain to others because I'm not one that likes to share if I'm in pain or hurting. I like to brush it off and say, oh, I'm fine.
When I described my pain, I know that I was heard, but I'm not sure that I was understood.
When I would tell others, like my friends or family, they would just say, oh, everybody deals with pain. You'll just have to get used to it.
Sometimes I was a little more comfortable, and then other times I was just miserable. Fortunately, I really didn't have a role in choosing the type of medications that I was prescribed.
I've tried a lot of different opioid medications, and all of them have given me side effects that I don't feel like is worth it for the pain relief.
There was just sort of a gap there in communication that I think could have helped my experience as a dialysis patient.
Looking back, one of the things that really could have been more helpful to my treatment is if we had tried some type of non-medical therapy to help me to deal with my pain without using medications at all. We are not alone in having pain. Over half of patients receiving dialysis treatment experience pain during any given week, and we are more sensitive to bad reactions to pain medications.
Studies show that hemodialysis patients who take opioid pain medications have a higher risk of falls, fractures, hospitalization, and death than those who don't. And pain itself is related to poor quality of life.
HOPE is a research study designed and geared specifically toward patients being treated with hemodialysis. And just so we're on the same page, HOPE stands for Hemodialysis Pain Reduction Effort. The main goal is to reduce how pain interferes with the lives of people who receive dialysis treatment.
The HOPE study is part of the National Institutes of Health HEAL initiative to find scientific solutions to stem the national opioid health crisis.
The study is funded by the National Institute of Diabetes and Digestive and Kidney Diseases, which is also known as NIDDK.
The HOPE study is testing 2 ways to improve pain management. The first method is called pain coping skills training and involves one-on-one sessions with a trained coach to learn skills to help you manage your pain.
The second method is a medication called buprenorphine, and it may treat your pain with fewer side effects than traditional opioid medications. You do not need to be on pain medication in order to participate in this study, and you will not be required to change your pain medication if you decide you want to enroll.
Most study visits will occur by telehealth or video chat with the study team. This means that you can arrange those visits to best fit your schedule.
Participation will last between 8 and 10 months, and you will receive compensation for contributing your time and effort to the study.
By participating in the HOPE study, you could help your fellow dialysis patients.
The knowledge gained by your participation in the HOPE study could help patients with their pain.
If you have been suffering from pain that has gone on for 3 months or more, and you think this study might be a good fit for you, please go to www.hopehdtrial.org or
Isn't that great? That video was written and produced by our patient advisors. I see, look at all the feedback there, Dawn. So that's the culmination of a lot of work and collaboration between our patient partners and the research team. So let me tell you a little bit about how we got there and how the study went. Dawn mentioned some of this. Like I said, she sort of patient engagement was baked in from the very beginning. It was a U01 funding mechanism. So each site proposed its own study, intervention, and design. But at the end, we all had to come together and iron out the protocols. So patients were involved before the sites submitted their initial protocols, and then at those meetings to really nail down the protocols. So they didn't come into a study that was set at all. Their input was critical in deciding how the study should unfold, what the intervention should be, how it should be delivered. Dawn already mentioned they were very literally at the table and not back behind the table for those discussions. And then I just wanted to talk about how did we involve the patients. In the interest of time, I'm just going to kind of go quickly. I think there were two main ways that patients got involved in the study in general. And at our site, we had one of each. One was, this was just an article that we had written about the risks of pain medications, opioid medications, and dialysis. And then after we wrote this, David White wrote a patient view editorial to accompany it, saying that patients should be involved in research. So I thought, well, if he thinks patients should be involved in research, I'm going to give him a call or shoot him an email and invite him to participate. And so that's what we did. And so David isn't local to us in Minnesota. He's actually was in New York at the time. But he also had an extensive resume here of already advocating for patients and being involved in a lot of activities. So that's one way, and that's one. Several of our advisors were chosen like that. Carolyn, who you saw in the video, also was chosen by the coordinating center because of other interactions in other environments. And then the other way is local patients that you take care of, that you think would be great contributors. And this is Joey Williams, who is one of our patients here in Minneapolis, who's currently on hemodialysis, and has just been a fantastic partner in the study. So those are the main two ways, at least for HOPE, that our patients have gotten involved. And then just how they've been involved is just at all stages of the study. They participated in steering committee meetings, the intervention and the design, as we said, but then also moving forward, the recruitment and retention committee that Dawn mentioned was a key committee where a lot of the patient advisors contributed. And I'm going to show you some about that in particular. But before I do, I just don't want to forget to say that there was also a patient advisory board, as well as, so patients participated in all of the regular study committees, including quality control and all of those, but also there was a patient advisory board where at various times, some of the other groups would come for input, such as how to implement the PCST intervention, what should be in there, that type of thing. Frozen again. Oh, there we go. Good. So I showed you the video, which is a key thing that came out of the recruitment and retention committee, but I also wanted to show you just briefly a little bit too about the other recruitment materials. So this was a mock-up that we sort of started from, and we worked with the patients in our committee to design the interventions. And one thing that happened that you could see in the video is they didn't like this, what HOPE originally stood for, which was hemodialysis opioid prescription effort. They didn't like the focus on opioids. They wanted it to be more about helping people and reducing pain. So we actually changed what HOPE actually stands for in the trial compared to what it was originally conceived. This logo here, they were actively involved in designing the logo and the tagline. The helping people on dialysis manage pain was really the emphasis that our patient advisors wanted our recruitment materials to have. And I seem to be stuck. Okay, I'm going to hope that you can still see. Well, I'm going to try. Here we go. Try it one more time. And then they liked the idea of all of these things, that pain could be anywhere and strike anyone. And they liked this idea of beating pain or getting control over it. So we took all of this mixture and sent it off to a graphics company that the coordinating center contacted, and they came back with this initially. And then the group said, well, we really do like this idea that this shows that pain could strike anyone, all different people, but we really think these faceless people are creepy. So let's try to rethink this. And this is what the brochure ended up with. So, you know, they really, and this was something that the group really felt like, yes, this is what we want to see. We want to see something that speaks to all of us. And so this is how the brochure looked. I am so sorry that I'm having all this trouble with my slides. And I just wanted to say too, that they were also involved in the consent form. The red text here that I've highlighted on the screen are the things where I remember the patients particularly contributing. So the focus of this research study is chronic pain. So again, wanted to make sure it was chronic pain, not opioid use per se, but an experience by people receiving dialysis, not patients, but people. And then again, as Dawn already mentioned, I think that focusing on the negative effects of pain and how people feel and participate in life activities. So this idea that the focus should be on pain and helping that and not solely on opioid reduction was very, very important. I'll skip over this next bit. And I think I've pretty much already gone over the fact that people were involved in all of the committees. So I'll just start to kind of wrap up here. In terms of ingredients that for effective patient engagement, what we found, and also what's out there in the literature, if you look at studies, some key things are respect for the patients, equitable power between the patients and the researchers, and a shared and collaborative decision-making process, and then trust, which is related to all of these things. And it's also good to try to, as much as possible, ensure diversity of patient advisors and inclusiveness so that the research will appeal to all sorts and will be generalizable to many different folks. And so the activities that you can do to develop those things, one is training and education for patients and the research methods. And Dawn mentioned this a little bit, that we tried very hard to make sure that we didn't use too many acronyms, but of course we sometimes did. And I hope we were very willing to step back and explain things as needed. And we tried to really educate patients along the way about what we were doing, why we were doing it. It's important to compensate patient partners for their efforts and not to ask them to donate their time. It's important to have regular bidirectional dialogue between patients and researchers and to involve them early, as we've already talked about here. So I just want to end on, we're actually working on a manuscript with the patient advisors to describe some of their experience. And so I put here some quotes from them directly about their experience, and again, some of the ideas I was talking about, that they felt welcomed and like my opinion mattered. And you don't always get that. One advisor said, in this project, it wasn't just lip service. People actually took our opinions seriously and took them to heart. And another patient talked about feeling empowered and how it can help others. And then one patient, said, I can go back to my community and tell them that what happened in the past is not happening today, and that research needs our input to be able to take better care of us. And finally, I'll just end here. One patient advisor said, it's not a committee, it's a community. So thank you for your attention.
Thank you so much, Kirsten. I love those quotes. I hope that we can save them and incorporate them into other talks and materials we share with our investigators, because it is so inspiring. So thank you for your presentation. Thank you to everyone who's worked with you as part of this effort. We're going to move on to the next set of presentations, and then we'll have some time for questions. So the next presenter duo is from the Justice Community Opioid Innovation Network, or JCOIN. We're honored to have two team members from JCOIN with us today. Linda Hurley and Rosemary Martin will be presenting on their project, Using Implementation Interventions and peer recovery support to improve opioid treatment outcomes in community supervision. So, to tell you a little bit about our speakers, Linda Hurley has worked in substance use disorder treatment and behavioral health care for over 35 years. And since 2016, she's been president and CEO of Kodak Behavioral Health Care, Rhode Island's oldest and largest nonprofit outpatient provider of treatment for substance use disorder with a specialty in opioid use disorder. Under her leadership, the Kodak launched a program with the Rhode Island Department of Corrections that was the first in the nation to screen and treat all incarcerated individuals for opioid use disorder. And that is a huge accomplishment. This landmark program has been expanded to Massachusetts, my home state, and is viewed as a model for the nation. Rosemary Martin is an associate professor in the Department of Behavioral and Social Sciences and the Center for Alcohol and Addiction at Brown University. Her work emphasizes improving access to evidence-based treatment for opioid use disorder, particularly among people involved in the criminal legal system. As part of the HEAL Justice Community Opioid Innovation Network, or JCOIN, she's studying a systems change approach for increasing the use of medications for opioid use disorder supervision setting, providing training and technical assistance support to frontline addiction treatment providers. So with many thanks in advance for your presentations, please take it away, Linda and Rosemary.
Hi there. Just give me one moment to set up here. Okay, good afternoon. I'm actually not going to introduce myself since Dr. Baker did such a nice job. Thank you for that wonderful introduction. And I'm going to note that Linda Hurley, who is my community partner, is having a hard time with her Wi-Fi once again. So she will, she'll join when we can, and I will kind of punt while I wait for her to come back. So here we go. So today, what I'm going to talk to you about is our Justice Community Opioid Innovation Network, or JCOIN for short, research. The goals for the next 15 minutes are to present the significance of providing evidence-based care for opioid use disorder in the criminal legal settings, briefly describe our JCOIN project, provide 3 examples of stakeholder engagement from our trial, along with sprinkling engagement throughout our presentation. Our format may be a little bit different than typical. When Linda and I co-present, we've been known just to jump in when we are moved to do so. You have been warned. So it may not be what you typically see, and when she gets her Wi-Fi back, you'll notice. So effectively reducing opioid overdose risk nationally requires promotion of evidence-based approaches in community settings and also in the criminal legal space. So JCOIN was launched by NIDA and is part of the NIH HEAL initiative. Our objective is to study approaches to increase high-quality care for people with opioid misuse and opioid use disorder in correctional settings. JCOIN is testing strategies to expand effective treatment and care in partnership with local and state justice systems and community-based treatment providers. That's really, really important that we're doing this in partnership with the justice agencies and treatment providers. And the overall goal is that every individual involved in the justice system with a substance use disorder should have access to evidence-based treatment while detained or in the community. So NIDA set the bar for the community engagement for JCOIN at the outset. Our research hubs were implored to include at least 1 criminal legal member and 1 community-based service provider member to be part of our investigative team. So our partners have been with us from the beginning as we were developing our research plans. They were part of the application process because it was mandated that we have these partners. And these partners, like what Dr. Johansson was saying is that they're part of the J-Coin steering committee. So there's a steering committee for our network, and they are they're members of that. Based on the specific project for a research hub, the level of engagement with the partners across hubs differs. So unlike the pain initiative of HEAL, where they're standing up one protocol, within J-Coin, the research hubs have their own protocols. And we are more than the sum of our parts because we're all working within the same system. So partners to facilitate evidence-based, evidence-informed, and community-defined change. In contrast to looking at the patient and engaging patients, as Dr. Johansson did, we are focusing on the criminal legal system. So the target of our intervention is the legal system, denoted by the pink star. Our Justice Community Innovation Network study is testing strategies to expand effective treatment and care in partnership with our justice system and our community-based provider. We acknowledge that individuals with opioid use and opioid use disorders are embedded within systems. And we are concentrating, just as this opioid ecosystem portrays, we are concentrating on two of these systems, the criminal legal and the community treatment provider. The natural progression of addiction, and more specifically OUD, leads to increasing use despite adverse consequences, which often includes involvement in the criminal legal system. 1 in 5 incarcerated individuals has OUD. Individuals with more severe OUD are more likely to become incarcerated. Unfortunately, this may begin a cycle that embeds someone further and further into the criminal legal system. From the outset, we acknowledge that racial and ethnic minoritized populations are at higher risk for lifetime likelihood of imprisonment, and that this overrepresentation contributes to deepening health disparities. Incarcerated persons are among the sickest members of our society. They have higher rates of chronic and infectious communicable diseases, mental illness, substance use disorder. Why do we care? Because these individuals will return to the community. So when we have approximately 650,000 individuals returning to the community with high rates of chronic disease and significant barriers to healthcare, we have an we have a public health crisis. When we look specifically at community supervision, 1 in 66 adults is supervised in the community. 60 to 80% of these individuals have substance use disorder, and following release from incarceration, people with OUD are often returned to opioid use and are at a significantly high risk of dying from overdose, up to 129 times more likely to die in the 2 weeks following release. So what can we do about it? Linda, are you on? All right, I'll keep going. We know that medications for opioid use disorder save lives. The FDA-approved medications include methadone, buprenorphine, and naltrexone. Research has demonstrated that positive findings within correctional settings when MUD is provided. It includes reductions in illicit substance use, criminal behavior, recidivism, HIV risk behaviors, overdose and mortality, and increases in treatment engagement after release. Notably, in our home state, in Rhode Island, when we initiated the MOUD program statewide, while someone was incarcerated, it was associated with the 61% reduction in post-release overdose deaths. All this said, within the community supervision space, only 2 to 10% receive medication for opioid use disorder. So we need diverse strategies to improve OUD treatment and engagement and retention for those in the criminal legal system, and particularly for improving transitions across systems of care, like incarceration from the community. Sorry. So why is, Linda, are you on?
I'm so sorry. The hotel here was, can you hear me?
Yes.
Okay, I'm on my phone. The hotel here has not been able to reconnect me to Wi-Fi. I went down about 10 minutes ago. But I am
Okay.
on and I can speak. So you let me know when you're ready, Rose. I'm so
Okay,
sorry,
so-
everyone.
That's okay. We're on the barriers to MOUD and community supervision. If you want to pick up from here, if not, I'll just keep going.
Well, I can speak to the barriers because you and I had talked a little bit about that. And barriers to MOUD and community supervision are actually, they're mirror images of some of the barriers that that were reflected with the community partners in treatment provision. And it's, so there's just a piece of the, there's a historic piece. I'm really sorry, you guys, I got my notes here. There's a historic piece that comes from decades of having biases because of lack of understanding, lack of knowledge, and often that is reflected in a feeling of lack of respect for the respective missions of each of these stakeholder groups. So a barrier to MOUD community supervision would be these biases. Like, you know, rehabilitation doesn't understand community safety and security. And from the rehabilitation or the treatment side, you know, these guys don't care about the patients. They just care about, you know, having too many people on their caseloads and making sure that they are not experiencing recidivism. So it's just like, you know, they're opposite sides of a coin, but it's still the same coin. So that the biases, there's funding, there's clearly a resource problem with many, and historically with practically all of the probation and parole officers in community corrections. And then again, I just want to state again, because it's so important, and I will get my bearings here, Rose, but it's really, really important that we understand that all of the biases and most of the barriers go back to, you know, not understanding the missions, not understanding the respective, you know, goals and priorities for these two groups of stakeholders.
All right, thanks, Linda. So the barriers truly are multi-level, right? They're at the level of each system, they're at the level of organizations, and they're at the level of the individual staff people. So our project is designed to address and overcome these barriers. So we called our project PEERS, Providing Interventions for Enhancing Recovery and Community Supervision. States, Rhode Island, Pennsylvania, and North Carolina. And our research institutions in Rhode Island, we have Brown University, University of Rhode Island. In Pennsylvania is Temple, and in North Carolina is Duke and the University of North Carolina, Chapel Hill. In Pennsylvania, Rhode Island, we're statewide, Pennsylvania and Philly, and in North Carolina, we're in Brunswick County. So I'm going to provide you with an overview of our study and aims, but I don't want to go into too much detail because I really want to kind of keep going with the momentum of focusing on community engagement. So our protocol is published in the Journal of Substance Abuse Treatment. The citation is on the slide for those of you who want more information. Briefly, we're using a hybrid type 1 trial implementation effectiveness design. In phase 1, we're evaluating a systems change approach for increasing evidence-based practices for OUD among community supervision settings. We're partnering with the community supervision offices and community treatment providers to engage a change process. In phase 2, we are conducting a randomized control trial of individuals under community supervision, and they'll be assigned to MOUD referral with peer support versus MOUD referral. For today's discussion, our comments are mostly focused in Rhode Island, but similar activities are happening in Philadelphia and Brunswick County North Carolina. So our systems change. We're guided by the exploration, preparation, implementation, sustainability, implementation framework. At each phase of EPIS, we have engaged our stakeholders and we'll provide examples of how we've done that. So preparation for systems change. The three examples that we're going to provide to you have to do with the preparation for systems change, training and education of the workforce, and a COVID telehealth survey that we did. So in terms of how we prepared for this trial, so early on, we met with supervision leadership. So Linda and I met with the Assistant Director of Rhode Island Department of Corrections, Steve Blanco, met with in Philadelphia with Public Safety, as did Lauren Brinkley Rubenstein in North Carolina, met with the Office of Public Safety. So we had been talking with the leadership of these departments, introducing them to what we wanted to do, the framework we were going to use. And within the departments, once we got rolling in Rhode Island, I went and did orientation or kickoff meetings with each probation office, or one of my co-investigators and one of our staff members too. And what does this mean? This means that we sat around the table with every probation officer and staff member before we started the trial. We provided an overview of what we wanted to accomplish. We described what our ask of them would be and how each person could participate. We asked for feedback. We provided them with that opportunity to ask questions, express concerns, and they did. They wanted to tell their stories. These turned into what I thought would be orientation sessions, turned into listening sessions. The probation officer, parole officers, and office staff told stories, gave examples of how difficult it is to help those on their caseload. They described how siloed they were from treatment providers, how at times the relationship between probation and treatment providers was actually iatrogenic. They wanted to better service those on their caseloads, but didn't have all of the information and tools that they needed, that they were operating within a system. They had the courts and they had limited influence on the courts. They were operating within their departments. And there they had some control and influence, and then they had to collaborate and operate within the treatment space. And there they were running into problems. And so the issues raised by the probation staff are precisely the issues that we're addressing in our study. Linda, do you want to talk about the treatment community? Sorry, I'll ask her to come back to that.
I'm back, Rose. I am so
Okay.
sorry. Okay.
Go ahead.
This has just been awful. So the way that we engaged the treatment community was we started with the Opioid Treatment Association of Rhode Island, and all but one opioid treatment provider are present with that community, and we invited them to also come in. And very much the same as what was spoken about with engagement with the patients for dialysis, and what Rose just spoke about the openness of parole officers and probation officers to really talk about the problems that have been historic and has actually, because of the pattern and the trend over the years, has become cultural, what these barriers were. And again, I said, it's very much, it's the same coin, it's just a flip side. So when we spoke to the leadership of the opioid treatment programs in Rhode Island, they also believed that there were barriers, that there wasn't an understanding of who they in reference to the relationship to the people that we serve. So it was very rehabilitation oriented. And again, it goes back to not understanding the missions of each of these stakeholders. As a matter of fact, less than 6 months ago, I was actually called by the head of community corrections in Rhode Island on a call with her supervisors and said, you know, what's 42 CFR and HIPAA, you know, all your staff see that as a barrier to communication. And there was a lot of issues around that. But my point here for telling you that is that this was 6 months ago. And that conversation was probably held with the same two people, me and the director, in 1994. So again, I think the culture is so embedded, and what is what is so exciting about how we engage the opioid treatment providers is that we again talked about, what do you need? Tell us what's so hard. What does your staff need? What do your patients need? How do you see the people in the community that need care and would need some support by creating this holding environment between whatever form of the justice system or the community corrections and treatment? And to me, that is really the key here, because they were so open to talk about what the barriers were. And as I said earlier, I kind of jumped in on the wrong slide there, but as I said earlier, you know, of course, there's, you know, very often treatment providers historically are required or want to, for the best possible reasons for best care, you know, commit to unfunded activities. So there is this resource problem around dollars. There's a resource problem about the workforce. And one of the second exciting pieces, not only was this an opportunity for treatment providers to be heard, it was also an opportunity for them to feel that there was going to be something different, that this systems change was going to create something better. So basically, I sold the systems change. That is exactly what this project is undertaking, is something that's going to be positive, and something that not only is it going to be positive for patient care, which is critical, but it's also going to be realistic. And it's going to be realistic because we are listening to all of the stakeholders. And I think that's the most important point from this, Rose. And then when we get to the other slides, I'll fill in.
So the next part after prepping is we engaged local change teams. The local change team are members of probation and treatment at the local level. And the LCT is driving the changes to the system. They're selecting the goals, they're developing an action plan, and they're carrying out that action plan. What Jcoin is providing to them is a professional facilitator for systems change. The gentleman here on the slide with the headphones on is Matt Russa, and he is a NIATEX trained professional, and he is the facilitator. This was one of our early meetings that was hybrid. Very soon after they started, they determined that they wanted to meet in person. That was important for them to sit around the table together. So they have been meeting in person, and soon we some of the changes that they have put into place. Their goal was to increase percent screened at intake for substance use disorder. They wanted to raise it from none to 100%, and they wanted to do it by the end of March. That is a formidable goal. And they wanted to increase percent referred to substance use treatment. So they determined this goal themselves. They're working with the leadership in the department to make this happen. They developed something called the SUDSI, a substance use disorder screening implementation that's going to be used with all intakes. And really excitingly, they have made the SUDSI screening part of their e-supervision module. So in a systems change approach, this is exactly what we want to see. We want to see something become sustained. We want it to be institutionalized. And as they're rolling this out, they're going from probation office to probation office, and they're stumbling over each other. This is the local change team members to go and present. They're that excited about this, and they want to do this. So Linda, can you just comment a little bit briefly on, from your perspective, how the local change team has been going for your providers that are on the team.
Surely. And it is exciting. That's the right word, Rose. They're very excited. We're excited. And I actually have walked in Rhode Island and Mass, and I've walked into two of the sites where I was saying, oh, what's going on? This is a nice luncheon, you have a meeting, just kind of checking in. And Rose wasn't informed, I wasn't informed. We as leaders, we weren't part of this. And it wasn't designed for us to be part of it. But what was thrilling was that it was working, because the local change teams were meeting twice. When I went 2 places, they were meeting, they were having lunch, the conversation, all the stakeholders in the room were so engaged.
And it's
and
that speaks to the process. Linda, sorry to cut you off. We are actually out of time, and I apologize. I can't go through my 2 next examples, but we did produce training and educational materials where we actually developed a multi-component evidence-based toolkit for community service providers. We did it with our partners, and it is hosted at in 3 places. I'm putting it up here, and it has had incredible reach and engagement, both nationwide and some international. And lastly, we developed a telehealth survey at the request of Linda, and that is going to wrap it up for us. The take home is we have been really trying to translate our research into specific action. Apologies for the problems that we have, and I will stop sharing now.
Thank you so much to you both. I really loved the presentations and input. I think that we'll be able to share the slides with anyone who registered for the webinar so that they can take their time in looking through them slowly and not feeling too rushed. But I did want to have time for just one question. And let's see. So the first question I will ask to Don and Linda. And then there's also a question in the chat here. So the first question I have is, what would this is a forum with a lot of people from different backgrounds, among them people with lived experience and also researchers. And so what is one piece of advice you would give to researchers, and what would you want them to know about your experience in research and your experience with HEAL? And I'll start with you, Don.
Thanks, Rebecca. One of the things that I would say that's really important for researchers to know is that, yes, there are barriers. Yes, there's history, and in certain communities, people may not feel comfortable participating in research, or they may have preconceived notions about research. But I think that if you break down those barriers and you go into the community and you meet people where they are, and you explain to them what the research is all about, what it is that you're trying to do, and let them know that we're trying to help people, and we're trying to make people healthier, and we want to empower people to share, so that you can learn and that we can change. I think that that's really important. And finally, I just want to say that if you do meet resistance, don't get discouraged. Move on to somebody else that may be a little bit better informed. Educate and empower, and just ask. Asking is is a big remover of barriers, and you find out that people are really interested in sharing. So that's how I feel about it. What do you think, Linda?
Well, I think, the principles you just described apply to any population, really, because what needs to happen and what's most important is that when you are engaging, individuals need to feel heard. And if they are heard, they're feeling respected, and that's the building of trust. That's particularly important when different groups of stakeholders don't have a history of trust. There hasn't been a way for that to build, or there's been actual barriers for it. So creating these systems that allow all of the stakeholders to be heard and feel that their perspectives are actually respected and valued is what is important. And I think if we talked about, speaking to researchers about this, I've been active in trying to in working towards applying research. And I think it's very important for the research community, as it's happening through this particular JCOIN initiative, to understand that providers also have a history, and the providers are, very often, 100 times I've heard, or more than that, oh geez, look, this study just came out, and that's just great, but it's 3 years old. There's 2 new substances in the field. They spent millions of dollars, and we still can't get the parking lot fixed. And I know that sounds very in the weeds, but that's really a perspective, and it's part of the culture. And that's what we're working, and what we're really taking that apart now and creating a sustainable relationship. And it's a really a magnificent thing. It's the best word I can find. Thank you.
Thank you, Linda. So I see that some of the questions and answers are being handled in the chat. So feel free to add your question or answer in there, or check it out. And then my last question will be for you, Rosemary. How have you found, and I know you've been in this field for some time, how has the engagement of people with lived experience in communities improved your research?
Oh, incredibly so. And one thing in terms of with there being collaboration, the buy-in, the buy-in is there, the motivation is there, and we're able to answer very important, difficult research questions. My training historically for decades was randomized control trials, laboratory-based applied research. And when I started doing community engaged research, it certainly opened up a new focus of turning science into something that I wanted to deliver quicker, faster, and better, because people on the other side were waiting for it. And so moving into a phase of doing more implementation science, where I'm looking at what are the evidence-based practices, how can we move this? How can we improve public health with what we know and with the tools that we have? And so that is sort of how my program of research has morphed and changed. And quite frankly, for me, it's far more personally more satisfying, and I think it is for my research team as well. And it's a lot more fun. And you know what? If it were if it were easy, somebody else would be doing it. The difficult stuff can be fun. And
well, I love that answer. That's how I feel. I think it's so easy to stand and look and say, oh, well, look at all these advances that haven't been taken up, or look at all these barriers. It can be overwhelming. And so it's just so inspiring to hear from you, fellow panelists, and everyone who's taken part, to learn about how we can overcome those barriers, and how we can really, through connection and through listening and collaboration, really improve the impact of our research. So thank you to everyone who took part today. In the chat here, you see that we'll have another one of these webinars in June, and you can register and join us then. Thank you, everyone, for your questions, for your participation, and for your contributions to NIH. I'm very grateful, and I wish you a wonderful weekend.
thank you. Thanks.
Bye-bye.